I have to tell you that, oh gosh, 15 years ago, I was making a lot of mistakes around this. I was only looking for an anterior tie, which is how the way I was taught, that if I saw that the tip of the tongue had a little piece of tissue attached to it and it wasn't extending past the lip, that's an obvious anterior tie. The American Academy of Pediatrics says that that's the most common tie. I actually don't agree with that. I think it's the one that's not as easily missed, and so people notice it first. But if you really learn how to examine a child for a tongue tie, and we'll talk about a lip tie in a second, what you really want to do is get under their tongue and elevate it up to the roof of their mouth so you can see how much the frenum, the little piece of tissue, is restricting the movement of the tongue, in addition to some other screening measures. So I look under every kid's tongue, but I do a specific exam with gloved fingers where I actually push up on their tongue and take a feel to determine how tight that tissue may be and how much restriction may be happening. But even if I detect that type of restriction, I'm not going to consider the fact that the child may need to be referred to an ENT or a pediatric dentist for a release until I see that child try to eat. And if I feel like that tie is impacting function, then I'm going to ask them to consult with a medical professional who would release it. Now, as a speech language pathologist, I'm not allowed to recommend a release because that's considered a medical procedure. But I am allowed to report on function for feeding. So one thing for parents to keep in mind is that ENTs, otolaryngologists, and pediatric dentists, they're not feeding specialists. They don't know about the developmental process of feeding. They just know about anatomy in the mouth and, of course, a million other things around that area. But they don't know about feeding. So my job is to communicate to them effectively how this restriction is preventing this child from becoming an adventurous eater or contributing to possibly reflux. And we do have some research about that. And how they're not able to move their tongue to maybe clean out those lateral sulci, right? That's so important to feel safe. Or move their tongue well enough to get food off the back of their tongue. Like if you've ever had a little piece of parsley stuck back there, you've got to be able to move your tongue well or you're going to gag and throw up. And that's one of the reasons a lot of these kids are so gaggy, is because they actually have a tie. Now, your upper lip is extremely important for propelling food backward as well. So when I see a child who has a restriction in their lip, that means they can't move their lip very well at all. Look how still my top lip is right now. My lower lip is overcompensating. What happens with those children as they grow is their top lip will begin to thin and recede like that. And their lower lip will get fuller. And they'll learn to swallow like this. And they'll actually build up this muscle right here. You'll get a little bulge right there because of overuse of this muscle. So it's not just a matter of function for feeding. It's also a matter of, as they grow, is it going to impact their appearance and the way they're able to propel food backwards? Some of these kids are still great breastfeeders, even with the ties. But more often than not, they have trouble with breastfeeding because they can't flange their lip really well around that breast in order to activate the touch receptors in the back of their throat and on their lips to get a great latch and compress their tongue and the breast to extract the milk. So my opinion is flip every lip, tip back every tongue, and examine every single child, 110%. I wish I had done it 15 years ago. I know I miss children all the time, and I'll never make that mistake again. So, but it depends on function. Not every kid needs a release. It's always about function.